Good evening, everyone. My name is Fadi Gerges. I'm a consultant cardiologist in Mediclinic Al Ain Hospital in UAE. I'm very privileged and honored to introduce to you today in our Anticoagulation Day or updates on anticoagulation realm. Two of our eminent speakers and professors, Dr. Adel Khalifa Sultan. He's a consultant cardiologist and Bahrain's first interventional cardiac electrophysiologist, in fact. Dr. Adel is basically doing electrophysiology and he's doing cardiac pacing, tachyarrhythmia device in Khalifa Cardiac Center in Bahrain, Military Hospital. It's a pleasure to have him today. He's basically as well the past president of the Gulf Heart Rhythm Society and the fellow of our Royal College of Physicians of Canada. He's board certified in both internal medicine and adult cardiology from the University of Toronto. So Dr. Adil will be talking today about the updates on anticoagulation in CD and ACS settings. Soon after Dr. Adil, we will have Dr. Mohammed Tariq Bakri. It's our privilege to have him as well. He's American board certified of internal medicine, and he's basically an assistant clinical professor in Michigan State University. Dr. Muhammad is an internal medical senior consultant in both SKMC in Abu Dhabi and Mafraq Hospital. And it's good to know as well that he's a chairman of Anticoagulation Task Force Committee. So we will be having a lot of his expertise in the setting of the anticoagulation and treatment of VTEs. So we'll start by Dr. Adel. Dr. Adel, the floor of yours. Basically, this is it's a very interesting lecture, the updates on anticoagulation in the CD and ACS settings, because it's, I mean, the audience, this is just a small message that almost 10% of all patients with recent PCI, they have concomitant AF. Others may have also concomitant VTE at the same time. So choosing the optimal antithrombotic regimen can be a real challenge. So let's start, please, Dr. Adel. The floor is yours. Thank you.
Thank you. Thank you, Dr. Fadi, for a very nice introduction. Good evening, ladies and gentlemen. First of all, allow me to thank the organizers for their kind invitation. It's indeed my great pleasure and honor to be here in this webinar. So let me share my slides first. I hope you can see it there.
It's clear, Dr. Adi, yeah.
Very good. So I was given the task to talk about updates on anticoagulation in stable coronary artery disease, but I will take the liberty to expand my talk a little bit to include scenarios related to AF and PCI and what are the latest clinical trials in this regard. These are my disclosures. So all of us know that AF is the most commonly encountered arrhythmia in clinical practice, and the prevalence increases with age, and this is based on European and US data. Furthermore, AF is considered a growing epidemic because the projected number of AF cases likely will increase by 2 to 2.5-fold in 30 years from now. Similarly, the proportion of a stroke attributable to AF also increases with increasing age from 2% in those patients between the ages of 50 to 59 to almost 24% in the octogenarians. AF is not a benign disease, and we always be honest to patients because they think that AF is a nuisance arrhythmia, while in reality it is not, because AF is associated with significant morbidity and mortality. And based on the Framingham Heart Study, it has been demonstrated very clearly that patients with non-valvular AF, they have 5-fold increase in the risk of a stroke compared to those without. Furthermore, and from the same data, it has been shown that the 30-day and 1-year mortality rates are significantly higher in patients with non-valvular AF compared to those without. So let us talk about some data from the local region. And the best study that I can recall is the Gulf Safe Registry, which was led by Professor Mohammed Zbaid, and I was privileged to be part of this study. This study have shown that patients with AF in GCC countries, they have five-fold increase in the risk of a stroke and twofold increase in the risk of mortality. And these alarming numbers mirrors and very close to international numbers related to AF burden. Furthermore, if you look at the prevalence growth rate in the region between 1990 to 2019, we can clearly see that the prevalence of AF, for example, in Bahrain, had increased by almost 500% over the last 30 years versus 800% in a country like Qatar and UAE. So GCC countries are facing an alarming increase in the number of AF patients. So before we dive into the actual presentation and the topic, let us just define and go some through definitions to make things easy when we discuss about clinical trials. So when we talk about dual therapy, we are talking about aspirin or P2Y12 inhibitor added to oral anticoagulation. While when we talk about a triple therapy, we are talking about adding aspirin and B2Y12 inhibitor to oral anticoagulation. While when we talk about dual antiplatelet therapy or DAPT, we are talking about combination of aspirin and B2Y12 inhibitors. So if we look at the spectrum of use of both oral anticoagulation and antiplatelet therapy in both indications, stent and AF, we can see that, for example, DAPT, they are very effective in preventing stent thrombosis, but by themselves, they are not really sufficient for stroke prevention. Similarly, if we look at oral anticoagulants like vitamin K antagonist and NOAC, they are very effective for stroke prevention, but again, by themselves, they are not suitable for new coronary events. So it makes sense that whenever we want to maintain a balance between stroke prevention and stent thrombosis, we have to combine the three agents together. Now, we have an ample evidence to suggest that the combination of triple therapy is quite effective. But the question is, are they safe? This slide is taken from a landmark meta-analysis, and probably it was the first meta-analysis which was published by Roth exactly 10 years ago, but still this meta-analysis, one of the backbone, and it is cited frequently in any paper that talks about NOAC. So in this meta-analysis, we looked at all phase 3 clinical trials, dabigatran in the RELY, rivaroxaban in the ROCKET AF, and apixaban in Aristotle, and edoxaban in the ENGAGE AF TIMI 48. And in a nutshell, we see that all these four agents result or associated with a significant reduction in a stroke or systemic embolism. And we are talking about here the relative risk reduction of nearly 19%. Similarly, all the agents associated with significant reduction in hemorrhagic stroke and intracranial hemorrhage with a hazard ratio of 0.50, while there was a 25% increase in the risk of GI bleeding. Finally, we can see that all these agents associated with 14% relative risk reduction of major bleeding. So let us actually delve more in the ENGAGE AF TIMI 48. And the reason why I chose this to talk about, because edoxaban, actually, we don't talk about it that frequently. Furthermore, edoxaban is the most recent NOAC approved for SPAF. In addition, the ENGAGE AF TIMI 48 is the largest phase 3 clinical trial of NOACs with patients included more than 21,000. And also, it is the longest study among all phase 3 clinical trials with a median duration of 2.8 years. Now, in a nutshell, and again, we're not going into details about this, but I think it's a good idea to understand where did we start in order to go further in a different concept. So, 21,000 patients, or probably more, with AF and moderate or severe risk of a stroke, they were randomized to either edoxaban 60 milligrams or edoxaban 30 milligrams or warfarin targeting INR between 2 and 3. Now, keep in mind that those who are randomized to edoxaban 60 or 30 milligrams, they can receive 50% reduction in the dose of edoxaban if their weight is 60 kilograms or less, if the creatinine clearance is 30 to 50 ml, and if they are taking concomitant strong P-glycoprotein inhibitor, which is verapamil and quinidine. And the protocol in the study was amended later on to include also dronedarone. And as shown in this slide, the Engage AF TIMI 48 reflect a diverse range of patients. And, I'm not going through them all, but you can see it in the slide. 10% of patients, they have low body weight. We have 28% patients, they have prior stroke or TIA, 36 patients and 40% patients, they have diabetes and they are elderly, respectively. Almost the vast majority, if not all patients, they are hypertensive. So it included risk factors that commonly we see in our patients. So what did we find from the Engage AFTME 58? Now, we said that there are two doses. Now, both doses, they were not superior to warfarin when it comes to the primary efficacy endpoint of a stroke or systemic embolism. So, you can see that the high dose is better than warfarin in the primary efficacy endpoint. The lower dose slightly worse, but none of them, they were statistically significant, although the higher dose reduces the primary efficacy endpoint compared to warfarin, but it misses statistical significance by narrow margin. But on the other hand, if we look at major bleed, we can see that both dosages, the 30 and the 60 milligrams, associated with significant reduction in major bleeding. And we are talking about the relative risk reduction of 20% in case of the high dose edoxaban and almost 53% in the lower dose edoxaban. Now, this is a subgroup analysis that extracted only patients who were taking edoxaban 60 milligrams and compared them to warfarin. Now, based on this cohort of patients, we can see that utilizing the 60 milligram edoxaban resulted in 21% relative risk reduction of a stroke and systemic embolism, with 47% relative risk reduction in hemorrhagic stroke, with similar rate of ischemic stroke. Again, this is another subgroup analysis from the Engage AF TIMI 48 that looked only at patients with coronary artery disease. And the number of patients in this cohort is 4,510, which represent roughly 21% from the total population. So these group of patients, or the 21%, they were analyzed for stroke and systemic embolism in addition to bleeding. And as you can see in this slide, edoxaban significantly reduced the risk of a stroke and systemic embolism, with a greater reduction in ischemic event, particularly in this group of patients, which is patients with coronary artery disease. Furthermore, the edoxaban safety was not really affected by coronary artery disease, although there is less bleeding in the edoxaban 60 compared to warfarin. So whenever we talk about clinical scenarios of patients with atrial fibrillation and coronary artery disease, we are talking about three scenarios. The first scenario is patients already has AF on NOAC, but then he end up requiring intervention for some reason or another. The second scenario is patients with recent ACS, of less than 1 year duration who develop a new onset AF and require anticoagulation. And the third scenario are patients with a chronic coronary syndrome. These who, for example, had CABG or PCI more than or equal to 1 year and develop AF. So these are the clinical scenarios that we face in clinical practice, and we will touch base on every scenario briefly. So let us start with the first scenario. Now, if you have a patient who has AF and developed acute coronary syndrome, then what we should do, from management point of view, we have to stop the NOAC immediately. We load them with aspirin, 150 to 300 milligrams, and then subsequent management depends on the type of acute coronary syndrome. If the patient is a STEMI, we load them with P2Y12 inhibitor, and obviously we refer them for primary PCI, which is the preferred approach to treat these patients. And once we decide that they need primary PCI, radial access is preferred, and a newer generation of drug-eluting stents should be implemented. And we can use anafractionated or low molecular weight heparin, but we should avoid GP2P3As and fundaparinux. If patients with a STEMI end up in a place where there is no primary PCI and consideration for fibrinolysis, then this by itself constitute a relative contraindication. And all attempts and all efforts should be made to refer these patients to a primary PCI center. And if this is not feasible, either practically or logistically, then we have to weigh risk-benefit ratio for these patients. Now, on the other hand, if a patient with acute coronary syndrome presented with non-STEMI, now it depends on the urgency of intervention. If the intervention of these patients is deemed immediate and urgent, then they should follow the pathway for primary PCI. If the non-STEMI acute coronary syndrome is considered to be non-urgent, then PCI can be delayed. And obviously the same thing, we can start fundaparinux, but we should avoid anafractionated heparin or 2B3A inhibitor. The last scenario, if a patient with AF on NOAC require elective PCI, then the same point, the NOAC should be stopped for at least 24 hours and avoid 2P3A inhibitors. Consideration for bypass or plain balloon angioplasty should be made. But if PCI is attempted, then we should use contemporary drug-eluting stent. Now, this is in the acute phase. Now, after the PCI, what management options will be there? And this is what we will talk about it shortly. I find this is very intriguing to talk about double versus triple therapy in AF. And let me just take you back in history to talk about vitamin K antagonist. One of the earliest studies that looked at double versus triple therapy was the Worcester trial. In this trial, 573 patients on oral anticoagulation. They were divided, and these patients, underwent actually PCI. And these patients, they were divided into two groups. The treatment group are those patients who received vitamin K antagonist and clopidogrel. And the control group, they received VKA, clopidogrel, and aspirin. Now, for those who underwent paired stent, clopidogrel was given only for 1 month and was stopped. And if they end up having a drug-eluting stent, then clopidogrel continued for 12 months. Now, in a nutshell, this trial, the WOS trial, have shown that dual therapy, VKA plus clopidogrel, associated with significant reduction in the primary endpoint of bleeding. Now, keep in mind that the WOS trial was not powered to determine efficacy endpoint. Similar result from the ISAR triple in 614 patients on oral anticoagulation underwent PCI. These again divided into two groups. The first group received VKA, clopidogrel, and aspirin, And the control group also, they receive the similar drug. The difference is in this clinical trial is comparing 6 weeks of clopidogrel versus 6 months of clopidogrel. And as you can see, that there is no difference in the net clinical benefit between these two groups. So let us talk about the second scenario where patients with recent ACS of less than 1 year who develop a new onset AF. Now, if we look at the NOAC trial and PCI, and this is by itself require a full talk and full presentation, but I will just summarize it in an aggregate. So the Pioneer AF PCI randomized 2,100 patients with AF into 3 groups. And remember, this study is quite complex because the first group received Riva 15 plus B2Y12 inhibitor. The second group received Riva 2.5 milligram twice daily plus DAPT for 1, 6, or 12 months. And after 1 or 6 months, patients, they were transitioned to Riva 15 plus aspirin. And the last group will receive the triple therapy of VKA and DAPT. And after 1 or 6 months, transitioned to VKA plus aspirin. And this actually, the conclusion from this study, it has been shown that the patients randomized to rivaroxaban associated with lower rates of bleeding compared to those in the warfarin arm, with no difference in terms of ischemic endpoints. But keep in mind that those who were randomized to rivaroxaban 15, that is not the typical dose that was used for stroke prevention. The redual AFPCI with dabigatran randomized 2,800 patients into 3 groups. The first group received dabigatran 150 milligram twice daily plus P2Y12. The second group, dabigatran 110 plus P2Y12. And the third group, which is the triple therapy, vitamin K antagonist plus DAPT, and transitioned to VKA plus B2Y12 after 3 months. And this study also have shown that dabigatran-based therapy associated with lower risk of bleeding, and it was not really inferior to triple therapy when it comes to thromboembolic event. Apixaban was tested in Augustus AF PCI trial, and this is the largest among all PCI NOAC clinical trials, where 4,600 patients, they were randomized to either apixaban 5 twice daily plus B2Y12 inhibitor versus vitamin K antagonist plus P2Y12 inhibitor. Now, after that, each group, they were randomized to either aspirin or a placebo. And keep in mind also that one of the criticism of this study is that there is a proportion of patients who did not really underwent PCI. Uh, uh, so the conclusion from this study is that, those who are randomized to apixaban plus P2Y12 inhibitor without aspirin, they have the least risk of developing bleeding compared to other groups. Similarly, the risk of ischemic burden was similar. Finally, the Entrust AF, which looked at edoxaban, and we will talk about it here, slightly in more details. So in this study, patients with AF for at least 12 months who underwent PCI, they were randomized to either edoxaban 60 milligrams per day plus B2Y12 inhibitor without aspirin. And similarly, the dose of edoxaban was reduced based on the criteria that I mentioned in the Engage AF TIMI 48. And the other group received vitamin K antagonists, which include B2Y2 inhibitor plus aspirin for 1 to 12 months. And the primary endpoint from this study was major or clinically relevant non-major bleeding. And when it comes to the primary endpoint, you can see that those who are randomized to edoxaban associated with 17% relative risk reduction of major bleeding and a clinically relevant non-major bleeding based on the intention to treat analysis compared to those who were randomized to vitamin K antagonists. And it was reassuring from the study that there was no significant difference when it comes to thromboembolic events. So if we took all these PCI NOAC clinical trials that was studied in this meta-analysis, and if we include all of them, we can see that all agents included in the AF PCI trials resulted in significant reduction in major or clinically relevant non-major bleeding with a risk ratio of 0.66. Also, when it comes to major bleeding, all these drugs resulted in 36% relative risk reduction of major bleed. All-cause death and cardiovascular death was the same between those who received dual antithrombotic therapy versus triple antithrombotic therapy. So there was no difference between the two groups when it comes to all-cause death and CV death. There is a slight increase in myocardial infarction in those group. There's roughly 22%, but was not statistically significant. But then there was a significant increase in stent thrombosis in those taking triple antithrombotic and those receiving dual antithrombotic therapy compared to those who receive the triple therapy. Now, this is another meta-analysis that looked at the four phase 3 clinical trials, but in patients with coronary artery disease this time. So we extracted data only in CAD patients. And as you can see in this slide, edoxaban was the only drug that resulted in 31% relative risk reduction in myocardial infarction. And it was also the only drug that resulted in 35% relative risk reduction of stroke or systemic embolism, while there was a trend toward reduction in major bleeding, but that was not statistically significant, and the relative reduction was 19%. So we have more robust data on edoxaban in patients with coronary artery disease. So putting things together, I think we will reach this famous slide that will dictate your management option in patients with AF and PCI. So the first scenario is patients with elective PCI. We start them on triple therapy for just 1 week. And after 1 week, we drop aspirin and we continue NOAC plus clopidogrel for 6 months. And starting from 6 months onward, we can give them NOAC monotherapy. Now, the second scenario is patients with ACS who underwent PCI. Then you have two options, either clopidogrel-based therapy or ticagrelol-based therapy. If you are planning to give them a clopidogrel, then you can use a triple therapy for a month. Then you drop the aspirin and you continue NOAC plus clopidogrel from 1 month until 1 year, and subsequently NOAC monotherapy. If you decide to give them ticagrelol, then you give the triple therapy for 1 week, and then from 1 week to 6 months, you give NOAC with ticagrelol, and after 6 months to 1 year, NOAC and clopidogrel, and subsequently you give them NOAC monotherapy. Now, despite this, you have to understand that this is not written in a stone and it's a very dynamic process. You can always shorten or intensify the combination therapy based on the bleeding risk and based on the atherothrombotic risk. The last scenario is patients with chronic coronary artery disease, like those who underwent CABG or PCI a year or more and develop AF. One of the early studies in that regard was the FIRE trial, which included 2,200 patients, and this was carried out in Japan, where these patients, they were randomized to receive uh, uh, rivaroxaban monotherapy versus rivaroxaban plus B2Y12 inhibitor, and it was kept under the discretion of the investigator or the treating physician. Now, keep in mind that this study was terminated early because of high mortality in the group of patients who received combination therapy. But nevertheless, if we look at the overall results, we can see that rivaroxaban monotherapy was non-inferior to combination therapy when it comes to the primary efficacy endpoint of stroke and systemic embolism, MI, and stable angina requiring revascularization, while rivaroxaban monotherapy was superior to combination therapy when it comes to the primary safety endpoint, which is major bleeding. So that was the first study that looked at monotherapy of NOAC in this group of patients. I will end up my presentation with one of the latest and hot topic in NOAC in patient with coronary artery disease, which is the EPIC CAD clinical trial. And that was just published, it was presented and published a couple of months ago. It was presented in the European Society of Cardiology in London, and simultaneously, the trial was published in the New England Journal of Medicine. And the EPIC CAD aimed at comparing the efficacy and safety of a standard dose edoxaban monotherapy against dual antithrombotic treatment, which is edoxaban plus single antiplatelet agent in patient with high risk atrial fibrillation and coronary artery disease. So in a way, similar to a FIRE clinical trial, one of the major differences is that the EPIC CAD included much higher risk patients compared to the previous clinical trial. This trial was carried out in 18 major cardiac centers in South Korea, a total number of 1,000 patients. They were randomized to edoxaban monotherapy versus dual antithrombotic therapy. The primary outcome was composite of death from any cause, MI, stroke, systemic embolism, unplanned urgent revascularization, and major bleeding or clinically relevant non-major bleeding. While the secondary outcome included individual endpoints from the primary outcome, in addition to composite of major ischemic events and safety outcome of major bleeding. And as you can see here, that the net adverse clinical events was lower with edoxaban monotherapy compared to dual antithrombotic therapy. In addition, there was a significant reduction in major bleeding or clinically relevant non-major bleed in the group randomized to edoxaban monotherapy compared to dual antithrombotic therapy with a relative risk reduction of 66%. While major ischemic events, they were the same. So I think with this, I don't have a conclusion in my slide, but I think I took you through a journey, from starting phase 3 clinical trials of NOACs, moving to some data on PCI and acute coronary syndrome to what is available in NOACs in patients with a chronic artery disease, ending up with this remarkable study that might change our practice, that these drugs are safe when used as a monotherapy. I think I will end up here, Mr. Chairman, and I'm willing to take questions. And just before I finish my slide, I would like to conclude that edoxaban monotherapy reduced the net adverse events compared with dual antithrombotic therapy when given as a long-term treatment in patients with AF and stable coronary artery disease. And this clinical benefit were supported by lower incidence of bleeding event and no increase in ischemic event. Thank you very much.
Thank you very much, Dr. Ada. That was really informative. And I think we already have questions, but like we can keep it just like save it till the end because I'm sure that we'll have questions as well for Dr. Muhammad. So thank you for the update on the anticoagulation and CED and ACS settings. It was very informative. Please, Dr. Muhammad, you can share with us your perspective on this interesting lecture. Next one. Thank you. The floor is yours.
Good evening, and thank you for everybody who's attending. Thank you for the organization company and to give me this opportunity to talk about a very challenging subject as usual. I think always anticoagulation is one of the topic which is bring a lot of challenge and difficulty and exciting either for the atrial fibrillation or for the VTE. For the next 20 minutes, basically, I'm going to present a few things which we already know as introduction to a couple of updates, especially for edoxaban, which was already presented in the European Society of Cardiology this September 2024. A couple of presentation, one of them really addressing the issue of can we use edoxaban without using the at least 5 days of low molecular weight heparin, was something we always face every day, and I get a question about every day. So nowadays, at least we have some real world evidence to talk about. Also, I will also talk a little bit about the cancer-associated thrombosis, because also we have a follow-up presentation in European Society of Cardiology to a previous presentation done last year about cancer-associated thrombosis. So to start with, I think all of us, we deal with VTE patient almost on a daily basis or at least a few times per month, especially for the people who does inpatient. We deal with it almost on a everyday basis. Like today, actually, I have at least 2 to 3 people with VTE on the medical ward under my care. And you can see the prevalence. This is from a cohort study in 2011. You can see about more than 3.5 million patients, they have VTE globally. Most of the time we see more DVT. You can see here about 62% of the people comes with DVT, either proximal or distal, and 38% of PE, which is usually the fatal VTE we deal with. If we look from the Gulf area, looking at Kuwait, Bahrain, Qatar, UAE, and Oman, we can see also the same thing. We're seeing about 77% of the cases as DVT, 15% of PE, isolated PE, and most of the patients, sometimes they can come with DVT and PE. And you can see at the lower part of the slide, which like we have the proximal DVT, which is the most dangerous one comparing to the distal DVT, where you will see higher chance of PE. So that's the reason proximal DVT is considered one of the high risk for PE, which can be fatal, at the same time for recurrent of VTE. So that's one of the criteria or one of the major characteristic we look at when we deal about, when we need to decide about extension of treatment. The burden of VTE is well known. It could be one of the fatal disease, and it's still considered the third, PE is the third cause of death after stroke and MI, especially if you're dealing with patient in the hospital. But many of those patients who survive the initial VTE, they might go into long-term devastating comorbidities and a problem in the form of post-traumatic syndrome, people with CTIF, and some people will have also right ventricular dysfunction, make their quality of life is challenging. So it's not only avoiding fatal event, we need to also look to reduce the risk of those complications to improve quality of life. If we deal also with thrombosis in cancer patient, you can see here on the slide that VTE or PE is considered the second cause of death in cancer patient, equal to infection. Of course, the first cause is progression of the cancer. So, and usually cancer, thrombosis in cancer is even a little bit more challenging than VTE without cancer, because those patients, they have higher mortality, they have higher risk of recurrence, and they have higher risk of bleeding, making it sometimes very difficult and challenging. We know now that the standard of care for treating VTE is, if you want to call it DUAC or NUAC, or sometimes we use it interchangeably. So, and based on many of the initial study done by all of the NUAC, apixaban, edoxaban, rivaroxaban, dabigatran. So you can see here, this is meta-analysis showing that it works as good as warfarin. So from efficacy-wise, it works very well. At the same time, it's now a standard of care because it's much easier, less burden on the patient. You don't need to follow the INR, less drug-drug interaction, and also from safety. Also, another meta-analysis, the same meta-analysis showed much less major bleeding, especially fatal and intracranial hemorrhage with DUAC than warfarin. And it's all reflected in all of the guidelines. So nowadays, hardly we use warfarin in very small cases if we cannot give the NUAC or DUAC. What's unique about the edoxaban and the Hoxai study, it is the only trial for all the NUAC which really address the reduced dose as part of the trial. So as already mentioned on the atrial fibrillation with edoxaban, you can use the 30 milligram or 60 milligram depending on some criteria. The criteria, again, just for reminder, with body weight less than 60 kilo, if the creatinine clearance less than 50, and if there is a specific certain PGP inhibitor like quinidine or verapamil or like other medication, where you really need to use the 30 milligram. And it's the only study as evidence-based with reduced dose. And also one of the largest study for VTE, where you can see it was compared with two groups. The first group started on parenteral anticoagulation for at least 5 days and switched to edoxaban, either 30 or 60, depending on the patient characteristic, versus the traditional or conventional way of using warfarin. And you can see the characteristic of the patient at the lower side of the slide, where especially if you look at this area, those patients with DVT, NPE, it was also significantly more extensive and more severe than the other studies. So for DVT, more than 40%, about 42 to 45 percent, they had extensive DVT involving the femoral and the iliac vein. And if you look at the PE patients, they had at least 1/3 of the patients, they had right ventricular dysfunction. So making those patients at higher risk of deterioration and a higher risk of mortality. That's the reason the study was designed to use the parental anticoagulation for at least 5 days, then going with edoxapan. And also you can see it was addressed. There was many patients with different characteristics, elderly above 75, patient with cancer, 90%, about 18% with multiple factor of bleeding. So they were really having a lot of severe patient and also fragile patient and patient at high risk of bleeding. And if you look at the trigger for the VTE, you can see that it was almost 2/3 without a specific trigger. What we used to do to say unprovoked, nowadays we try to really say no trigger. And about temporary risk factor, about 1/3 of those patients, 20% of them, they had a previous VTE. So it was all addressing variety of VTE causes, which what we see in our practice. And again, looking here for the PE population in particular, you can see that the majority of those patients, they were either in the intermediate or extensive group, making them at higher risk of mortality and deterioration. And that's the reason, again, we gave the at least 5 days of parental anticoagulation. And as you see here on the left side, from efficacy-wise, it was 11% reduction in the relative risk, but it was non-inferior. And on the right side, you can see that it was much less bleeding. And in particular, this is edoxapan showed comparing with other DUAC, it showed less clinical relevant non-major bleeding comparing with the other. But as we said, when we did the meta-analysis, all of the NUAC has less major bleeds than warfarin. So the first update, which presented in European Society of Cardiology this September 2024, is the COMMAND VTE Registry 2. Basically looking at edoxapan outcome in acute VTE without using the 5 days parenteral anticoagulation. So we already mentioned why in the study it was used, because most of those patients were really high risk, and that was the design for the study. But from pharmacokinetic view, we had before that, edoxapan work as fast as low molecular weight heparin in reduction of thrombin generation. So they looked at the patient from January 2015 to August 2020. They looked in 31 centers in Japan, about 5,200 patients. You can see that NUAC is the most common anticoagulation as a standard of care. You can see also it was edoxapan, apixaban was used more than the other in those centers. Then they looked at edoxapan patient and they divided them into the PE patient and DVT. And they looked at how many patients they were giving initial heparin, then the edoxapan, or without heparin, then edoxapan. So you can see here in the PE group, about 23% of those patients was not given the initial parental anticoagulation, which is really a good percentage of those patients with PE. In DVT, you can see it was about almost 19 to 20%. So again, although the study design and the label for the medication to be used after at least 5 days of anticoagulation, we can see that in real life and in the practice, in a good percentage, it was used without the 5 days of parental anticoagulation. And they were able to bear about 200 patients in the PE group and a little bit above 200 in the DVT group. And the study objective was really to look at the effectiveness and safety of using edoxaban without the parental anticoagulation and start the edoxaban right away. The composite endpoint was looking at this, major bleeding, and recurrent VTE. So you can see here the baseline characteristic of the PE patients were like divided into 195 patients in each group, and it was basically match. You can see also good percentage at the lower part of the slide. Good percentage they have a simplified PE severity score above 1. So those patients was not always at the lower side, lower risk, basically. And for the DVT, also they match about 226 in each group. And you can see that the majority of those patients were proximal DVT, so they are at higher risk. Isolated distal, you can see at the lower side, it was about a quarter of the patient. The rest of the characteristics were equal. So if we look at the PE patient, on the right side, you can see the 30-day composite endpoint. It was similar in both groups who received the heparin or without heparin, then edoxaban. And if we look at 30-day mortality, it was also exactly the same. And when they look at each individual component, it was also the same. And for DVT patient, exactly, we can see the same issue for 30-day composite endpoint using edoxaban with heparin or without heparin was exactly the same 30-day mortality and each individual component. So that's really now we have evidence real world setting where we can consider using edoxaban effectively and safely for VTE or PE treatment without the parental anticoagulation. Although I have to mention that basically in the label, because of the previous study design, in the label, it's written you have to give at least 5 days of low molecular weight heparin before you go with edoxaban. But in reality, we know that sometimes that might be a little bit difficult. So that at least assure us that in patients, especially the people who's not at a very high risk, they don't need to be admitted to the hospital. You can consider it, and you have to address the patient-to-patient profile. So switching to cancer-associated thrombosis, which I already mentioned, it's a challenging, more even sometimes a VTE patient without cancer because they are at higher risk of mortality, bleeding, recurrence, and so on. The minute we give the diagnosis of cancer, whatever cancer we give the diagnosis to the patient, you can see that the risk of VTE goes fourfold. And during the journey of the cancer patient, this VTE risk goes up and down. So you can see any hospitalization, any surgery, patients started on chemotherapy. If they have metastases, they always increase the risk of the VTE. And as we already mentioned, it's the second cause of death in cancer in cancer patient. Till recently, the guidelines, the standard of care was low molecular weight heparin for all the cancer patient with thrombosis. But because in the last few years we had trials compared the safety and efficacy of NOAC with low molecular weight heparin, the Hoxi VTE cancer trial in edoxaban, the Select DD in rivaroxaban, and other with the apixaban, also a couple of study. So nowadays things are changed, and we can consider the NOAC for cancer-associated thrombosis. A quick thing about the Hoxi VTE cancer. Again, you can see it was one of the largest trial for CAT. And you can see it was also the longest, up to 12 months. Most of the other study was for 6 months. And basically, you can see it's exactly the same design, where at least 5 days of low molecular weight heparin, then edoxaban, also reduce dose if it's suitable for the patient as the previous VTE. And you can see also characteristic of the patient down in the lower part of the slide. So you can see, looking at the composite recurrent venous thromboembolism or major bleeding, it was non-inferior to the dalteparin. If you look at the recurrence from efficacy-wise, it was even better with NOAC, but it was offset by increase in the major bleedings, and it was mostly from the GI cancer malignancy. So that's the reason, and also similar in the other study with the other NOAC. So that's the reason now the new guidelines from the Oncology Association organization. You can see here from the ACCO 2023 that now you can have the option of using edoxaban, rivaroxaban, or apixaban for at least 6 months, or you can use the low molecular weight heparin. But for the people with GI cancer, especially the upper GI cancer, or high risk of cancer with genitourinary or mucosal bleeding, you need to be very careful. And sometimes maybe the best way to go with the low molecular weight heparin. But whenever you decide to use NOAC in cancer patient, it's very, very important to look at the drug-drug interactions. That's the reason we depend a lot on our clinical pharmacist, because no way we can really remember all the drug-drug interaction. And as an example, you can see here also a study published in the European Respiratory Review in 2022. They looked at non-small cell cancer patient who developed VTE and treated with NOAC. They look at the combination of the different kind of NOACs with small molecular inhibitor. You can see that edoxaban, there was no interaction with this class of medication. On the other hand, the other one, like rivaroxaban, apixaban, and dabigatran, they had more interaction. About 50% of the cases, they used to either switch the anticoagulation, the NOAC, or they needed to really adjust the dosing, cutting the dose or separating the medication from others. And you can see here in the table, it's a busy one, but if you just concentrate on the colors, basically the yellow color and the green are the safest color. And you can see with edoxaban, it was all yellow and green, where with apixaban and dabigatran, they had to really do some adjustment and maybe sometimes to switch to edoxaban. And you can see with rivaroxaban, the majority is red. So that's the reason edoxaban, even with VTE without cancer, when we deal with patients with polypharmacy, they had the lowest drug-drug interaction. Another study, they looked at the same, looking at other chemotherapy, also other targeted therapy. You can see it was also repeated again, where edoxaban, you can see more green, or the majority is green. So it's more the preferred NOAC when you deal with cancer with thrombosis, as efficacy and also lower drug-drug interaction. And regarding the duration with cancer associated thrombosis, most of the study, as we said, except the Hoxha cancer, it was 6 months. The Hoxha cancer trial was up to 12 months. And the recommendation now is really to do extension of anticoagulation if there is no absolute contraindication for people with active cancer, especially if they have metastasis disease or receiving chemotherapy, because they are at the highest risk of recurrence. And this process is really dynamic. It needs to be reviewed every few months, looking at the benefit and the risk, and also have the patient preference when we're dealing with the extension. But most of the time, if no other contraindication, active cancer most likely will be on anticoagulation for almost for a long time. And you can see this also in the European Society of Cardiology risk factor categorization for long-term VTE. You can see it was divided into three groups. The highest group, which is more than 8% per year risk of recurrence, you can see active cancer is one of them. So that's the reason, if no other major issue, the anticoagulation most likely will be for life. Of course, the category which is the most difficult one is the intermediate category, which is 3 to 8% per year risk of recurrence. Those the cases nowadays we have the option to do extension of anticoagulation, again basing on of the risk and benefit of efficacy and bleeding, and of course the patient preference. For the major trigger, we treat for 3 months, then we stop. So looking at the cancer-associated thrombosis, as we mentioned, most of the study was up to 6 months, and the guidelines was really talking mostly about the 6 months. But now with edoxaban, we had a study which really looked again at longer duration, up to 12 months. Initially, the OncoDVT study was presented in the European Society of Cardiology in 2023, and I will give you a quick summary of that. Then this year, they did post-hoc subgroup analysis looking at the low body weight cancer patient with isolated distal deep vein thrombosis to see is there any difference. So the initial trial and publication, they took about 604 cancer patient with different type of cancer with isolated distal DVT. And they looked at if we treat them with edoxaban for 3 months versus 12 months, are we getting more bleeding, or are we getting less or equal, and what about the efficacy? So they looked at composite of recurrence of VTE and any death related to VTE as a primary input, and also for secondary, they looked at major bleeding. And you can see at the summary down there in the green box that basically people who was treated for 12 months, they did much better in reducing the symptomatic recurrent of VTE or VTE related death, and there was no difference in the rate of major bleeding. So this year, they did a post hoc analysis, subgroup analysis for those. They looked at, is there difference with the low body weight cancer, which is something we see in the cancer patient, versus normal body weight cancer, looking again at the same endpoints. And you can see here they had about 322 patients in each group. All of those people with low body, just by the criteria, they got the edoxaban 30 milligram, where the other non-low body weight, they had about 50% of them took the 30 and 50% took the 60 milligram. And you can see also on the top of the low body weight, some of those patients, they had another reason to reduce the dose, such as creatinine clearance less than 50, and they were really at higher risk of bleeding, looking at all the characteristic of the patient. So looking at the result on the left side, from efficacy-wise, there was significant lower rates of primary endpoint, which is symptomatic recurrent of VTE or death related to VTE in both groups, the low body weight and the non-body weight. On the right side, if you see for the major bleed as a secondary endpoint, there was a significant difference in the group. So you can see with low body weight, which they are really at high risk of a bleed, using the edoxaban up to 12 months, it didn't really show any increase in the major bleed, while in the normal body weight, it was on the border of statistical significant, where a little bit more risk of major bleed. So that's the reason now that give us really more confidence for those cancer patients with low body weight, and they might have other reason like a creatinine clearance less than 50, a fragile patient. It's really safe to give the edoxaban 30 milligram and to extend it up to 12 months. And that was the conclusion. Thank you very much.
Thank you very much, Dr. Mohammed Tariq. Really appreciate this. This was very enlightening lecture, and thank you for sharing your knowledge and dedication in advancing our understanding of anticoagulation therapy and in these complex situations, cancer-associated thrombosis and VT as well. I think we already have questions from the respected audience. I do have questions for you, our respected eminent speakers, but let's start with the audience. I'll just start with the first question. So this one is for Dr. Adel. The question is, when it comes to the elderly population who require DWAC or NWAC, what are your preferences, Dr. Adel?
Well, I think this is a difficult question, and I don't want to be in the corner here to state which NOAC is better, because all of them has great data on patients in the elderly. So let me just start by saying, what is the definition of elderly? Elderly were defined in the clinical trials are those who are 75 years of age or older. And if we look at phase 3 clinical trials, we have roughly 30 to 40% of patients included that belong to this age group, which equals roughly 27,000. So all the clinical trials included elderly population, and all the clinical trials have shown efficacy and safety in this particular vulnerable group of patients. So there is no one agent which is better than other. But I would like to highlight one aspect related to this question. If you have elderly people who are not suitable for the conventional NOAC for whatever reason, there is a study called the Elder Care AF, which was done in Japan, which included patients who are 80 years or above. These patients, they are not fit to be started on the usual dose of NOAC. These group of patients, they were randomized to receive ultra dose edoxaban at 15 milligram. And This drug at 50 milligram, which is the ultra dose, which is not really tested in phase 3 clinical trials, associated with 4.4 absolute risk reduction of stroke with non-significant absolute increase in the risk of bleeding. So the 15 milligrams in somebody who is not fit for any NOAC might be an option to use edoxaban 15 milligram. But keep in mind that this study, the elder care, was done in the Japanese population. Whether this can be translated in other population, I don't know.
Agreed, Dr. Adel. Very good answer. I think, like you said, it's a very difficult question, and it's a little bit of generalizing because we have to identify many things, like frailty score, for example, in those elderly population, and what kind of medications are they on? Because we have to also take a whole of the big picture and see what kind of medications interacting with our anticoagulant, DOAC or NOAC, and just avoid this medication as well. This is one thing. I believe that it's not about the double dose or the reduced dose for those patients regarding the kidney impairment or a reduced dose regarding other conditions like the weight and the age. Because like you said, many studies were implemented on the 4 DWACs that we have in the market. And most of the studies have proved that they are safe. We had some backfires from other studies that we had, for example, in dabigatran, some bleeding risk in elderly population. In the literature, it's very obvious, but in those populations, you are right that we cannot identify which patients are liable for bleeding or not, unless they start with a NOAC. But we just know that NOAC is much better for them compared with VKA, except for sure the non-valvular AF patients. Thank you very much, Dr. Adel. I think we have another question from Dr. Maha Haggo. I believe this is also for Dr. Adel. The question is CABG and peripheral artery disease, diabetes, and new AF, old ischemic stroke. Can we consider? I think the doctor had a bit of like a mix of those comorbid conditions with the patients. I'll just repeat it. CABG, the patient has CABG, has peripheral artery disease, he has diabetes and new AF on top of an old ischemic stroke. The question is, can we consider clopidogrel and edoxaban or just solo edoxaban in this patient?
Well, I mean, we have to apply the CHA2DS2-VASc score. So I can see that the patient had CABG and peripheral arterial disease. So he had a vascular risk factor. He has diabetes, and he has a ischemic stroke, which is like, 2 points. So this patient has a CHA2DS2-VASc score of 4. So, I mean, he will need a NOAC. I wouldn't say edoxaban, but he will need to have a NOAC. Now, there are other variables you just mentioned, kidney function, weight. We need to adjust the dosing based on other parameters. This is a different story. But this is like a CHA2DS2-VASc score of 4. He needs to be on a NOAC.
Great. I think the question also, he meant that shall we add clopidogrel on top of NOAC, which for sure we don't need it. It's not an indication. The patient doesn't have an ACS. The patient doesn't have a new stroke. In addition, that even if we have this criteria, the patient should be only on NOAC. It's a very high risk that we add another P2Y12 or an antiplatelet like clopidogrel in addition to the edoxaban, since the patient didn't have any acute insult. Thank you very much, Dr. Adam. This next question is for Dr. Bakri about the COMMAND VTA study. It was clearly shown that edoxaban can be safely administered without low molecular weight heparin, but still we see a lot of bridging occurs with low molecular weight heparin, and despite all that, the label still shows to combine with low molecular weight heparin. Any idea why? This is a question.
So basically, that's the reason I put the initial study design, because this is where, the FDA and so on, they looked at that study. So the design was at least 5 days of parental anticoagulation, and it got the label because of that. And since then, we didn't really have any data, or of course, we don't have any randomized control study. So it's a real world data. Many of the thrombosis expert and so on, they were using it, what is off label. And usually my advice, if the patient really has extensive DVT or like, severe PE, of course, those patients needs a low molecular weight heparin, but that's not only for edexaban, that's also for any other NOAC patients. So any patient really needs to be admitted with severe or extensive. I think it's the best way to go with low molecular, because there is some benefit of the heparin on the top of the just the anticoagulation. The company basically will not be able to talk about it because it's off-label. There is no randomized study. But in reality, it was done, and we see now, like, 20% or 25% of people, even with PE, it showed it worked. So my intake will be, if you have no problem to give the 5 days of low molecular heparin, go ahead. I think it's better to stick with it. But if you're gonna really deny the patient the benefit of edoxaban, if you believe that edoxaban is the perfect medication for that patient, and there will be a problem with giving the 5 days of enoxaparin, then we have now real world data to support us.
Very good. Next question as well to Dr. Bakri from an anonymous attendee. I was surprised not to see any subgroup analysis showing patients with CAT or catheter-associated thrombosis and CKD on dialysis. And all the studies you kindly showed, were they excluded out of the studies for a reason? And is still the usage of apixaban 2.5 milligram BID as an off-label still valid in this era?
Can you repeat the last part? Apixaban or edoxaban?
Apixaban 2.5
Okay.
milligram BID as an
So,
off-label.
so basically, this is one of the almost everyday question I get. We have to differentiate atrial fibrillation from VTE. I mean, the studies, the dosage, and everything is completely different. So we cannot really apply whatever for atrial fibrillation to VTE. And in reality, most of the study with VTE, we don't do any reduction in the dosage. So most of the NUAC 15 and above, we can give. The only one which we showed the trial was designed with reduced dose is the edoxaban. Otherwise, the apixaban you need to do for atrial fibrillation, you have the other criteria. But for VTE, no study done to show that low dose is enough. So we don't really adjust the rivaroxaban, we don't adjust the apixaban. So now if you're dealing with, so even if it's apixaban above 15 creatinine clearance, it should be 5 BID. The loading dose is the same. But if we're dealing with dialysis patient, that's even the most difficult patient because we don't have any data. At least with atrial fibrillation, we have guidelines. We have some even small trial to tell us to use 5 or 2.5 and so on. But in VTE, there is no study whatsoever to tell us. Again, in such cases, if the patient can be on warfarin, I usually advise warfarin. But if the patient is not going to be following the INR, then we can try to apply the dosage for atrial fibrillation. But again, this is off-label. There is no study to support this. And those are one of the most difficult group to make a decision on, but sometimes you have to do it.
Very good. Next question. For very obese patients, what is the preferred anticoagulant? Is it warfarin versus low molecular weight heparin versus heparin? I think this is a bit of a generalized question because we're not sure what is the profile of this patient. And for very obese or morbidly obese patients, I think there is no difference, but I mean, there is no contraindication to start NOAC for those kind of patients. According to the profile. However, I think the warfarin is indicated for still two subsets of patients, which is the non-valvular AFib and the antiphospholipid antibody syndrome. There's no guidelines at all to start to give NOAC for antiphospholipid antibody syndrome, still warfarin, VKA. So would you like to comment on this question? Shall we move?
Is it for obesity? Obesity also is a very complex subject because obese people, they have differences in drug distribution and drug concentration. And as we discussed briefly, all the NOACs or some of the NOAC phase 3 clinical trials, they've included weight adjustment in their entry criteria. But in a nutshell, and just to summarize this complex issue, there should not be a problem up to BMI of 40. So you can use all the NOACs. Between 40 to 50, the evidence is less robust and it is controversial. So we can use NOAC in this group, but preferably we can adjust based on the trough value of the NOAC. Above the BMI of 50, there is no evidence at all. And at that point, we might consider VK. So less than 40, we can use. 40 to 50, the evidence is not great. It's controversial. Above 50, we don't have evidence at all for NOACs.
Where we're not involved in the trials above 50 BMI.
Yeah.
Okay, very good. Another question for how to manage VTE with CKD, chronic kidney disease, on hemodialysis. It's a very controversial topic. Would you
I
like
think
to
we
answer?
already addressed it. I think it's the same answer. So,
Like the previous one, exactly.
yeah.
I think we've addressed this as well with the apixaban question. Okay, the next question, I think it's for Dr. Adel. Indications and duration of NOAC in AF patients with unstable coronary heart disease.
Well, that was the topic of tonight. So we we spent half an hour talking about this, and I'm not going to repeat the indication, but unstable CAD means patients, they will need PCI, and these group of patients, obviously, they need to have a triple therapy for 1 month if we choose a clopidogrel, and 1 month to 1 year uh, only NOAC with a clopidogrel, and after 1 year monotherapy with NOAC. If we choose ticagrelol, we can use a triple therapy for 1 week, and from 1 week to 6 months, dual therapy with NOAC and ticagrelol, and from 6 months to 1 year, NOAC with clopidogrel, and after 1 year monotherapy. So that was what we discussed earlier.
Exactly. In detail. Yeah, that's right. Okay, this is my question to you, Dr. Adel. We know that we have four DWACs or NOACs in the market. Three of them is factor 10A inhibitors like the rivaroxaban, apixaban, and edoxaban, and the other fourth is dabigatran, which has a different mechanism of action. It's basically a direct thrombin inhibitor. But we have antidotes now it's been a while for both DWACs. Which is basically for the factor 10 inhibitor, we have the andexanate alpha, and we have the idarucizumab for the dabigatran, the direct thrombin inhibitor. So if there are a role right now for those kind of antidotes of our NOACs, like for example, in a STEMI patient who presented for primary PCI and was already on NOAC, and he, for the reason, for example, for an AFib, so shall we use this antidotes for those kind of patients who are going through a primary PCI just before the primary PCI, or that will just like not mentioned in the literature or the guidelines, and we can just go ahead and do the primary PCI first?
Well, I think this is also a very complex topic, and having a reversal agent does not mean that we can use it randomly and haphazardly in all patients. Let me start with andexanet alpha. So the trial with andexanet alpha was used for patients with intracerebral hemorrhage, I think 2/3 of patients, and the remaining 1/3 those with GI bleeding. It was not even tested for surgery, like reversal before surgery. So that was the trial that was tested in andexanet alpha. When it comes to idarucizumab also was tested in two groups: those with life-threatening bleeding, or in patients as a pre-op for emergency surgery. There was no trial on the use of these reversal agents prior to PCI. And keep in mind that although both drugs, they don't have thromboembolic complications after reversal, but still this does not mean that we can use them for PCI. We don't have data yet.
Okay, very good. My last question is for Dr. Bakir regarding the gastric malignancy or the gastrointestinal malignancy. It's a bit of a complex situation when we have to use anticoagulant in those patients. Those patients usually have the tendency for bleeding and coagulopathy on the other hand, both things. So it's very difficult to weigh the benefit against the risk. However, it's mentioned in the guidelines, as you said, that there's no any literature, any guidelines saying that we can still use an WAC in those kind of patients. So the best treatment for this patient, is it low molecular weight heparin or VKA? Because NOAC will be basically increasing the risk of bleeding in those gastrointestinal malignancy patients.
So basically, all the guidelines they say if you're going to use the NOAC in GI cancer, it's not absolute contraindication. So you can use it, but the risk of a bleeding is going to be really high. So this decision usually is very difficult. You need to talk to the patient. The preferred one in all the guidelines is the low molecular weight heparin. But let's say the patient adamantly refusing the injection. So are we going to leave him without anticoagulation? Not. So then we need to tell him, look, this is the data, this is the risk. If you don't want to go with the injection, our next best one is NOAC, even better than warfarin. So warfarin is the last choice usually. So in such cases, you can still give it, but you have to be monitoring the patient and so on. And this is a decision needs to be clearly explained to the patient. So the preferred is low molecular weight heparin, especially in the upper GI cancer. But if the patient, for some reason, not compliant, doesn't want to go with injection, still we can, but we have to monitor, and the risk is there.
So we have to go with VKA and monitor the TTR more closely.
No, we can go with DUAC. I think still DUAC is the preferred after warfarin is usually the last one. If
So
we cannot give low molecular, if we cannot give DUAC.
there's any specific data on a specific DOAC which can be used? Because I think that the
Basically, I think the NCCN guidelines, they specified apixaban in the upper GI cancer or upper GI lesions. They gave it a step ahead of everything. But again, the data is not clear, is not very strong. But as we said, I mean, it's usually decision with the patient. Most of the time, if you explain this well to the patient, they will go with the low molecular. But if not, then we cannot leave them without treatment.
Great. We have a lot of other questions, but I think it's all similar to the ones you've addressed. We don't have to go through it, and I apologize for the respected audience, but you already mentioned also the same answers for the other questions. Thank you very much, Dr. Adel and Dr. Tariq, for this amazing lectures. It's very enlightening, and I'm privileged to have you on board. I hope we can meet physically soon. Thank you for sharing your experience and material and recent studies to me and to the audience. Thanks to Saj and ICOM for the nice invitation. Thanks very much. Hope to see you soon.
Thank you, Dr. Fadi, and nice meeting you, Dr. Tariq.
Nice meeting you. Thank you.
Thank you very much. Thank you. You
Bye.
too.